You are sitting in your hostile OPD and you see a patient who complains of sharp pain, photophobia, foreign body sensation, tearing, discomfort with blinking, blurred vision, and a history of scratching or hitting of the eye. You ask the patient to sit on the sit lamp and you see you do a detailed workup on a slit lamp. In the slit lamp you use a fluorescein dye to stain the cornea, and you see a epithelial defect. Then you measure the height and the width of the abrasion. You also note down the diagrammatic representation of the corneal abrasion, and then you evaluate for any foreign body in the eye, any infiltrate, and means any underlying corneal opacification, any anterior chamber reaction, any hyphema, corneal laceration, and any penetrating trauma. Then you evert the eyelid to ensure that there is no foreign body in the conjunctival fornix, especially in vertical or linear abrasions. The signs that you see the important signs are that epithelial defect that stains with fluorescein, that is suggestive of corneal abrasion. There is absence of underlying corneal opacifications, and if there is presence of underlying corneal opacification, it indicates any infection or inflammation. Other signs that you see are the conjunctival ingestion, the swollen eyelids, and mild AC reaction. Differential diagnosis of conjunctival abrasion is recurrent erosion, herpes simplex keratitis, confluent SPKs, the SPKs which have merged together and then give rise to confluent SPKs, ultraviolet keratopathy, exposure keratopathy, neurotrophic keratopathy, or any chemical burn. So now coming on to the treatment part is you ask the patient that is there any history of wearing a contact lens or not wearing a contact lens. So if there is a history of if there is no history of wearing a contact lens, you give an antibiotic ointment. It could be erythromycin, bacitracin, or bacitracin polymyxin B combination 4 times a day while awake, or you can use antibiotic eye drops like polymyxin B, trimethoprim, or any fluoroquinolone eye drop 4 times a day. Now, any abrasion that is secondary to fingernail or a vegetable matter, it should be covered with a fluoroquinolone eye drop like moxifloxacin, bacifloxacin, and ofloxacin, or ciprofloxacin at least 4 times a day. Now, if there is a history of wearing contact lenses in this patient, so you should give anti-pseudomonal coverage, that is fluoroquinolone. You may use any antibiotic ointment or antibiotic drops at least 4 times a day. Now, whether to use an eye drop or an eye ointment, so the decision to use drop versus ointment, it depends on the need of the patient. What the ointment do, they offer better barrier and lubricating function between the eyelid and the abrasion, but they tend to blur the vision temporarily. They may be used to augment drops at bedtime. We generally prefer ointments. So after the ointment, the second medication that you give is a cycloplegic agent. We mostly give cyclopentolate 1% to 2% twice a day, or 4 times or 3 times a day for traumatic iritis. Traumatic iritis can develop 24 to 72 hours after trauma. Now, avoid use of steroid for iritis with epithelial defect because it may impede epithelial healing and increase the risk of infection. So steroid is a big no for traumatic iritis. Also avoid the use of long-acting cycloplegics for small abrasions to allow a faster visual recovery. If we talk about patching, so it is really necessary and it can cause serious abrasion if it's not applied properly. Means the eyes are half open, you put a patch, so it causes serious abrasion. Also, patching should be avoided in non-contact lens related corneal abrasions. Why? Due to the higher risk of infection. Alright. We can consider a short course of topical non-steroidal anti-inflammatory drug NSAID eye drops like ketorolac 4 times a day for 3 days for pain control. Topical NSAID should be avoided in patients with other ocular surface diseases like dry eye. Oral acetaminophen or narcotics in severe cases can also be used for the control of pain. One thing to be noted is that never prescribe topical, never prescribe topical anesthetics like proparacaine, tetracaine, for analgesia. Why? Because it may delay epithelial healing and it increases infection and ulceration risk. So never prescribe topical anesthetic drugs. If there is any hanging epithelium or any loose epithelium, so it should be debrided because it inhibits healing. A cotton tip applicator which is soaked in topical anesthetic like proparacaine or a sterile jeweler's forceps used with caution may be utilized to debride or remove the hanging or the loose epithelium. Bandage contact lens may be used to improve comfort and protect the epithelium during healing. But one thing to be kept in mind is that contact lenses are rarely used in emergency room setting out of concern for patient compliance and follow-up. So if a bandage contact lens is placed in the eye, patient should use prophylactic topical antibiotics like fluoroquinolone or polymyxin B trimethoprim combination and should be monitored closely for epithelial healing and contact lens replacement. Do not use for abrasions. Do not ever use for abrasions which are associated with contact lens wear or if any concern for infection occurs. So, in how to follow up a patient of corneal abrasion. If you have patched the patient or you have given bandage contact lens, the patient should return in 24 hours or sooner if the symptoms worsens for re-evaluation. Secondly, if there is a central or large corneal abrasion, return the patient to next day to determine if the epithelial defect is improving. So, if the abrasion is healing, you may see the patient 2 to 3 days later. Now, instruct patient to return sooner if the symptoms worsen. Revisit every 3 to 5 days until the corneal abrasion heals completely. Secondly, if the corneal abrasion is in the periphery or if it's a small abrasion, return 2 to 5 days later. Also instruct the patient to return sooner if the symptoms, in case the symptoms worsen. Revisit every 3 to 5 days until the abrasion heals. Now, if we talk about the contact lens wearer, close follow up until the epithelial defect resolves and then treat with topical antibiotics. Alright, so close follow up until the epithelial defect resolves and then treat with topical antibiotics like the fluoroquinolone drops for an additional 1 to 2 days. The patient may resume contact lens wear after the eyes feels normal for a week after cessation of the proper medication course. One thing to be kept in mind that this time the patient should use a new contact lens.